Miss Summers,
Here.
Miss Newman. Let's see on there.
Did she call me?
I did.
I'm sorry. I'm trying to hook up my speakers. I can't hear well. I'm here.
Okay. Dr. Taub,
Here.
Dr. Hans,
Here.
Miss Root,
Here.
Mr. Landsman, Mr. Furman,
Present.
Miss Bernard, Mr. Torres, Mr. Lindemere, Miss Namie Dyer,
Here.
Dr. Guadalupe.
Here. Thank you. So we will go to our first item on the agenda, which is our first opportunity for public comment. Not sure who's monitoring that today, but if whomever is could let us know if there's any public comment, please.
Came from Lynn McGinnity, and she would like us to provide the public comment for her, and I'll go ahead and read that. It says, greeting honorable board members. We appreciate and thank OCHN and their administration for agreeing to continue to cost reimburse vocational service providers until March 31st. I am writing to ask that OCHN consider extending their cost reimbursement model for vocational providers until at least the end of June. New gateways and similar vocational programs have been open and operating at approximately 25 to 30% capacity since the fall. We have seen a slight uptick of participant return since the vaccine. We are being told that this may not occur until early to late spring. Most of our program participants cannot tolerate wearing PPE and cannot return until they receive the vaccine. It is imperative that we continue to keep the provider network whole during these uncertain times. We appreciate your attention and consideration regarding this matter. Kind regards, Lynn McGinnity, Executive Director of New Gateways.
Okay, thank you for that comment, and we will make sure that customer services follows up with regards to that.
All right. We also had another public comment, and it was a request regarding are there any other dates in February to speak at this meeting, because they had a prior engagement. That public comment has been forwarded to customer service. And then the final public
asking if they could come to a different meeting. I'm sorry.
Yes, they said, are there any other dates in February to speak at this meeting? I only asked because I'm on call at the hospital that evening. So we will let them know that there is an opportunity to speak at the board meeting next week. We'll have customer service respond.
Thank you.
And the final public comment for this evening is from Cheryl Loveday, and she is the executive director at Angels Place. She indicated, many OCHN consumers who reside in self-directed and unlicensed group settings meet the criteria for the 1A grouping to receive the COVID vaccine now. The OCHD, Oakland County Health Division, is responsible for conducting the vaccination clinics for this group. To date, providers have had no indication of when this vulnerable group of OCHN consumers will fall under the 1A assisted living facility designation will be vaccinated. We have had vaccine clinics canceled, citing a shortage of the vaccines, and yet citizens in the 1B grouping are now able to get vaccinated. We are not objecting to the right of other groups to be vaccinated. On the contrary, our concern is specific to the needs of those who are responsible to serve. We would like to acknowledge the OCHN's efforts with this matter and the support we have received during this pandemic. Thank you on behalf of MALA and the Oakland Provider Alliance. We are asking for OCHN's continued help with addressing this need through further advocacy and partnership with OCHD to get this 1A grouping of Oakland County citizens and their support staff vaccinated promptly. Thank you.
All right, thank
And
you very
that's-
much. And we will, again, make sure that customer service responds to that. Was there additional public comment?
Oh, sorry, I didn't mean to interrupt, Sarah. No, we do not have any additional public comment, but we do want to let everyone know there is an opportunity at the end for public comment, and they can provide public comment on our website. And that's it. Thank you.
Great, thank you so much. Okay, we will now move on to our next agenda item, which is a financial review with Anya.
Okay, can everybody hear me? Okay, I'm seeing Sarah shake her head. You can move to the first slide. So these are December financials. What you're looking at is revenue, which also gives you a glance at January, and you can see the blue line that goes across the chart there is the prior year. So you can see we're well above the prior year at this point. And that's entirely due to the eligibility, which is the next slide, if you want to jump over there. So eligibility still continues to be up significantly over last year. And we'll continue to see that throughout, I would say at least this fiscal year, if not a little longer, because once someone qualifies for Medicaid, they are eligible for a year. And so that won't be redetermined for another year. So that does help us from a revenue perspective. So we are still seeing revenue above what we have budgeted. So we'll continue to monitor that and keep you updated throughout the year. Next slide, please. So what you're looking at here is a comparison of the end of September 2020 to December of 2020. So really only a couple of months difference in time period, but you can see in the blue bars here, this first one, cash and investments, is up compared to that time period. That's primarily going to be due to the direct care wage pass through that came in, I believe it was November. So we did get the $2 that goes through the end of the calendar year in November. And then you can see that receivables is going down compared to September. And that's just us as we go through our annual closeout process of making sure everybody gets paid anything that was due to them from the prior fiscal year. Other assets is not terribly different. And then capital assets, being buildings and things like that, just goes down every month on schedule. Next slide, please. So this is a comparison of the same two time periods for liabilities. So you can see liabilities are down significantly. Again, that's just us clearing out any money due to providers or the state or whomever. So you can see due to state has gone down just slightly. Employee payables is up, but not much. And then long-term debt continues to go down. Again, that's going to be your depreciation and things like that. Next slide, please. So what you can see here, our net position comparing September to December is not much different. I called it even if we're talking about it, when you're talking about this large of a number, it really hasn't changed much. But again, this is only really a 2 month or so time difference. So I wouldn't expect it to be materially different. Total liabilities has gone down. So our total net position has actually gone up. And that's because our assets have roughly stayed the same. Our liabilities have gone down. So that means our net position has gone up or has gotten better. Next slide, please. So the revenue comparison, so this actually compares year over year. So now we're talking about a full year apart here, December of 19 to December of 2020. And you can see our Medicaid revenues up significantly. That's going to, again, be primarily due to that eligibility trend. And then I think we did, between those two time periods, have a couple of rate adjustments and some slight adjustments to our capitation rate. You can see general fund is almost exactly the same. County funds is exactly the same. And then all other is not materially different either. Next slide, please. So expense comparisons, again, this is the year-over-year comparison. So this is looking at December of 19 versus 20 or December of 2020. Administration is down. That's a material difference in administration, but if you recall, that really has to do with how we reclassified some things in administration when we restructured the GL. So it's not really that administration went down, that it's just where we're categorizing things when we redid that did change. So going into the 2022, you won't see that kind of difference anymore. You can see provider network expenses are down through December compared to the December before. And quite honestly, that's really more what we're seeing right now is a bit of a lag. So you heard in public comment, and you all know that we have people primarily on cost reimbursed contracts. So what we're doing is, because there's still some providers are still not producing a lot of encounters, which would typically drive their payments. What we're doing is paying them an estimated amount and then reimbursing anything that's outside of that, that's their actual expenses. So we're just seeing a bit of a delay. So it's taking a little longer to process some of those things. So the $2 enhancement is totally cost reimbursed. So they report it to us after they pay it out, so we have the exact number, and then we reimburse it. So the timing is a little different right now just because of that situation. So that'll start to catch back up as providers are able to go off of the cost reimbursed contracts, but that's really been kind of on a quarterly basis. We're reassessing that, and also really kind of when it doesn't make the most sense for providers and for the people served, just to make sure that we are maintaining a stable network. Grants down slightly, but that's really just grants that were not continued between the 2 fiscal years, and then all others roughly the same as well. Next slide, please. Okay, so net position total revenue is up comparatively to last December. Total expenses are down, so that means our net income is significantly higher. Next slide, please. So this is the top 15 providers, and fingers crossed the next chart did get updated to match this time. And this just shows the top 15 providers paid in December based on the amounts. And then the next slide should be the description of those particular providers. That's not the slide I thought it was going to be, but I can talk about this one as well. So we did have a question from one of the board members. You all, now we keep some data about the number of individuals served on our website. And so we did get a question of why there was what appears to be a material drop in the number of individuals served between fiscal year 20 and 21. So we just threw this in here, so it gave me an opportunity to talk about it to make sure that everyone understood that chart. And the way it works is throughout the year, we only count individuals served once. So they could be served 100 times, they're only going to be counted in this count once. So as we go throughout the year, we'll start to see that pick up. We do see a bit of seasonality with the spring and the summer and kids not being in school and things like that. So we do see a bit of a pickup in the summer months and things. So this doesn't concern me at this point. We'll start to see this pick up, and we should easily make the 2020 numbers, and I would actually venture to guess we will exceed those. And this is the slide that should match the top 15 providers this month. And should anyone have any questions about that, I can certainly take those, or any other questions related to the financials.
I see someone's hand up here. I think it was John Paul.
Yeah.
Yep.
Yeah, it's my hand. Thanks, Anya. Just a question, and you may have said this before. I'm just trying to reflect back on the grants, that there was a decrease. What were the grants that there was a decrease on? Did we lose grants, or was it just we didn't continue some?
So I don't know the specific grants off the top of my head. We can certainly get you that information, but sometimes grants just don't get continued. We had a couple that expired, I believe, in fiscal year 21, and not that we didn't apply for them again. They just maybe had been 2-year grants or something like that. So I can look into that, and we can get you that information.
Yeah, any information you can get me on. I was just particularly interested. I know we had a few with regards to the criminal justice and things like that, so I was just more interested. But if you can just pass that information along to me, I'd appreciate it.
Yep, no problem. I know they're all, if in the meantime you want to look at, they're all listed in the annual plan, the ones we knew of at the time. That doesn't mean things could not have been added, but we can definitely look at what ones were different between the 2 fiscal years just and give you those specifically.
Okay, thank you.
Yeah.
Adam?
The number of individuals served looked like it decreased from 2019 through 2020 fiscal year. Are we assuming that that was due to people not being comfortable due to the pandemic?
So that change between 19 and 20 was actually due to an error we found with how the number of individuals served in the SUD network was being collected. So I'll try to give you the short version of this. We used to have the substance use network in a different system. They were served, their EHR was a different system. And so we would have to pull that information into our system. And so there was a bit of overlap. And so we found an error in that and had to correct that. And that's why you see that dip from fiscal year 19 to 20.
Okay, thank you.
Yep.
Anya, I had one quick question for you. Now that we're rolling into almost a year of the pandemic and different working conditions and things, will you guys be evaluating any cost savings with folks working at home and not being in the building? I presume like heating costs are probably down a little bit, or are there any cost savings with folks not being there?
So we still do have tenants that do come in and out of the building. We do have some staff that have to come in and out of the building. So I have heard it's a bit chilly in the building, so there's probably some heating savings. To my knowledge, so based on just the amount that's hitting the budget for administration, I'm not seeing material differences. Because the reality is the building still has to be up and in running order, especially with tenants in it. It's not like we can just shut it down, turn everything off and say, we'll see you in, a couple of months. We do have providers that are still going in. We have staff that still have to go in to deal with deliveries and mail and things like that. So to some degree, we still have to keep it inhabitable, for lack of a better word. So I'm not seeing any material changes. I'm sure that the coffee bill is far less. So that's probably a savings, and maybe the electricity down a bit. But other than that, it's really, I'm not seeing material differences because everything still really has to keep moving and keep up and running.
Okay. Thank you. All right. Anyone else have any questions for Anya? Not seeing any, so thank you very much. We appreciate your report and update. So we will move on to our next item on the agenda, which is our contract obligations. And Christine.
Good afternoon, everyone. I was having a little bit of technical difficulty. So in previous conversations over the years, we have talked a little bit here and there about expanding on our awareness and advertising efforts. And if you can move forward, Suzanne, we decided to explore some options. First, we were talking specifically about Channel 4. And then we decided to include Channel 7 and asked for proposals on relatively conservative contracts that we felt would complement our existing efforts. So if you could move forward. Separately, one is contract is for $50,000, the other one is for $51,000, but combined total. And we felt like since it was both, they were both network and television related, we should bring this to the board for its approval because combined they exceed the $100,000 amount. And the contracts are each for 6 months. That would last throughout this year, and then the commercials would be embedded into our existing marketing plan. The goal, first and foremost, was to improve connection of people to services. Secondly, I know Dana has talked about this significantly with the board and during our interviews to enhance branding and awareness in part to position us well for future conversations about privatization and for us to be recognized as a leading healthcare provider. Next slide. So this is the proposal from Channel 4. Total number of spots. Now this would be for each month, would be 160. These are the programs where we would be featured. One thing you'll notice in here, they have click on Detroit and they have display ads with impressions. Impressions are determined based on an algorithm of if a program has X amount of ratings and we know that this many people may or may not watch the program, what's the probability of the number of times someone may or may not see your ad during the month? Next slide. And then this is the proposal from Channel 7, which is very similar. The one thing that's different about Channel 7 or Scripps is that they also own and manage Bounce and Channel 20. Their impressions these impressions were specific for Channel 7, which I think are a little low. Their pricing and the spots differ, I think, because we are on several stations instead of one single station. Some of the things to note about both contracts that are important is the development of the commercials is included in the contract price. The other thing that has been really beneficial to us, which we have found with our Comcast and our cable advertising, is once the commercials are produced, even after they have finished airing on the station, we get to keep the spots and we include them in our social media. We keep them on our website. So even though we're no longer advertising on the television stations, we still get to utilize and take advantage of the creative that was developed for us by both of the stations. So this would be on a consent agenda item on the regular board. Oh, I see a hand. I can't see whose hand, but I do see a hand that has gone up.
Jonathan.
Jonathan.
Yes, but I didn't want to interrupt you until you were done with this aspect because you were starting to describe some of this.
Oh, that's
but
okay.
I can give you my question. So this cost that they're charging us includes the development of any future spots?
So it includes the cost of all spots developed by the stations. What is beneficial to us is even after our contract has expired, so the commercials are no longer airing on their stations, we get to utilize them in any way we want. We still technically own the creative, so we can put them on our websites, we can put them on our social media posts, we can put them on YouTube. We have full access to continue utilizing the messaging. And so we do try to keep it somewhat generic. We do have some ads that are COVID specific that we have run this past year, but we try to keep them relatively generic and relevant so that they can be used at a future time.
Okay, so if we have something developed by Scripps, by the Channel 7, Channel 20 folks,
Mm-hmm.
could we actually reuse that and put that out on Channel 4?
You couldn't put that out on a different station. Because their airtime, you're purchasing airtime from them. So part of purchasing that airtime would be the development of the ad. Both ads would be similar anyhow. Like the messaging wouldn't vary too much between 4 and 7. They'll use the same script that we develop with them, and the content will look similar for branding purposes, so that whether someone's watching 4 or 7, the ads look close enough where they are associated with our organization.
Okay, so those productions cost, it's buried in there. Okay.
It is buried in there.
Thanks.
And I do have, and just the way the agenda is set up, in my quarterly report, I do have some metrics that I can share on how we would measure the outcomes of the commercials, but we needed to go through this presentation before we get to the next.
Okay, thank you so much.
Mm-hmm. Next slide, please. Are there any questions?
Christine, it's Sarah.
Hi,
so
Sarah.
when they develop, it sounds like they do the production or development, are they, are we providing them with information on being inclusive with the diverse populations we serve, or trying to, if they're including folks, I mean, are we utilizing people that we serve, or how does that work?
So we generally don't utilize people we serve in advertisements for a number of purposes and reasons. You just, sometimes people may want to volunteer for something and then afterward are a little hesitant. Sometimes people leave the system. So there are a number of reasons where we try to stay to using talents or images. We have the conversation about diversity, people we serve, inclusive language, all of those things. So they're working on creatives right now just to give us some ideas of what it would look like. We reviewed some of their suggested materials and then we'll send them back. We'll also share the spots with the people we serve, like through the CAC or the CEEC, any of those groups for input. We are sticking primarily to 15-second spots. I know it doesn't sound like a lot of time, but the attention span of the average American in terms of watching a commercial, 15 spots, you can purchase more, so the volume is greater, and the most important part is really our name and number and where people need to go for help.
I guess so. We are making sure, though, in terms of encompassing the different areas that we serve, because I know a lot of times we tend to focus a lot on mental health, where we also have, substance use disorders and intellectual, disorders. So just making sure that as we're promoting the agency that we're
actually in the spots that we're creating there, they highlight each program area individually. So we are being sensitive to making sure that all aspects of our organization are represented, as well as diversity in the use of pictures, inclusion, other input too that we've had in past years from the people we serve about things that they want to see in ads and things that make them feel respected.
Great, thank you. All right, anyone else have any questions or comments for Christine regarding these contracts? So you will bring this to the board for as a consent agenda during our board meeting?
Yeah, it'll be a consent agenda for approval.
All right.
Sarah, I just wanted to say something while we're on that topic. So for those that are not familiar with what a consent agenda is versus the regular board items, everything that's within that consent agenda will be voted on once as approved, okay, rather than having them all split out, okay? So if someone wants to have it split out, they can do that at the board meeting. We'll ask if if someone wants to change that consent or remove an item from there and break it out to make it a regular line item in the agenda. But, all right, because I know we haven't used consent agendas that much in the past. That was it. Thanks, Sarah.
Thank you. Okay, you get to stay on with us, Christine. Next is going to be the quarterly updates for communications.
Yeah, and so hopefully this will tie in to help you understand how we will be measuring some of those metrics in terms of the success of those contracts. We did keep them rather modest intentionally so that we would be able to determine, is this something that we want to expand on? Is this something we want to do in the future? And so that ties into my quarterly report. If you could go to the next slide, Suzanne. Just a reminder about my team, or the communications community outreach team. There are 4 of us, and really our role is to disseminate information, retrieve information, and I try to keep things concise, and we read a lot, research a lot, write and design and coordinate, and then we repeat. So I'd like to think of us as the gatekeepers of information for this organization, but also I think equally as important is to highlight all the work and effort by the people in our building, especially people who are directly involved with the service delivery system, and just to make sure that people are aware of the programs that are available to them and the innovation that goes on in that building, and just to highlight the talent and the skill there in the ways that it's utilized to benefit people's lives. Next slide. Specifically, I was asked to do an update about our advocacy efforts. I broke this topic down into 3 conversations just so the board would have a better understanding of the way we manage advocacy and our perception of advocacy. So the 3 topics I wanted to cover were what we consider to be primary and secondary advocacy, examples of some of our advocacy efforts first quarter, and then to review some of the outcomes from our efforts. The next slide. So advocacy falls under communication, and the primary reason is to increase knowledge of the public mental health system and OCHN by promoting our initiatives and our community outreach efforts. Our goal is to link people to resources, address concerns, and then inspire change, which is one of the primary goals of advocacy. When I talk about primary, usually that is an activity where we have taken a lead role. So here I put support professionals, and I'm really talking about direct care wages. And even though that's a statewide initiative, last year our advocacy work group had asked if we would develop a portal of some sort to recruit direct care professionals. And so we took the lead in developing that page as an advocacy effort, and then it's part of a larger statewide initiative. When I talk about secondary, it's really either sponsorships or attending events. So here I have NAMI. We are always actively involved in the NAMI walk. But anytime anyone in our building and anyone on our staff is sitting in a committee, or they're attending a community event, or they're on a task force, and we are on well over 100, that is an example of a secondary action for advocacy. I mean, we really are, each person in our organization who goes out and speaks and educates the community about our service network is an advocate on that level. So if you ever hear me say primary, secondary advocacy, that's how we're reviewing that topic. It's ongoing. We have people in meetings, I would say daily across the county, usually in person, but now it's all virtual. But the outcomes we're really looking for in these efforts is to increase engagement for people we serve and our network providers and our community partners. So I feel like we serve as role models of what it looks like to be an advocate, and that we encourage people to follow that lead and become involved. So next slide. All of the communication and outreach initiatives surrounding advocacy and any of our other work is funded through administrative dollars or grant funding, and usually included in the FY21 budget. We will build upon those events that we know are annual, and then we do leave some room for initiatives that might be presented to us throughout the new year. So, any questions so far? I see no hands, so I'm going to move forward. So the 3 examples I chose for this presentation include faith-based veterans and voting. I know that we've talked significantly about faith-based in the last few months. This is an area that Dana identified as a priority, as wanting to strengthen our relationships. So we worked in the first quarter to update our email list, to revise the names, make sure we had current names of contacts with people, and we started to send direct mailings to the faith-based community, asking them to subscribe to our listserv so that they could be on our emails with flyers and information about events coming up or anything related to our system. The other area was veterans, because Veterans Day is in November. We did have some grant funding that was available, and we hosted a workshop specific for veterans. And then, of course, it was an election year, so voting was a priority for us all of 2020. And, I'm really happy to say we create the presentation, but the presentation itself is given by people who receive services, as well as Mark Jones from our customer service team. So we had 4 different webinars that we hosted. We know that it was viewed by our clubhouses. A number of providers had said they would send it out to people they serve. So we had a significant amount of engagement in terms of people viewing the voting. What was also really nice is we took this information and we gave it to all of the other PIPs and CMHs and allowed them to remove our logo and update pertinent information in their community, so that our voting initiative really extended beyond our borders and reached out to communities all across the state. And then, you know, we do these scheduled based on annual events. Like I said, Veterans Day we know is coming up. If we know voting is going on, if there's something that's specific to the faith-based community, then we will tag on to those activities. And that would again be an example of a secondary advocacy initiative. Outcomes always to improve engagement. We want to see attendance grow at events, and then in doing so, we hope to create awareness. So next slide. All of our events are virtual, but I did want to share 2019, and the Abilities Awareness was the last event we had in 2020. I frequently tell people what's the most special about our activities is the engagement of our staff with the engagement of the people we serve. Like, you will see all of us walking together and talking together and advocating with one voice, and that is more unique probably than people realize, to see that type of an energy and synergy and a relationship rooted in, I think, deep mutual respect and admiration for one another. So I just wanted to share these so you can get a glimpse of what it looks like and what it's going to look like in the future. Any other questions?
I'm not seeing any. Oh, John Paul.
Not seeing either.
I just had a quick question, as somewhat related. Are we still recording the meetings? I know we used to record the board meetings and had like a YouTube channel. Is that something that we're still doing in the era of everything virtual and COVID?
Yeah, so this meeting is being recorded. If you look at the top of the screen, it'll say recording has started.
Okay.
And then we post the meetings on our YouTube channel, and they're accessible on our website still.
Oh, good, good. Okay. So yeah, I think that's a good way too for people to be able to see, you know, and know about what's going on and those kinds of things if they can't be right at the meeting. So, okay, thank you.
Yeah, and then we also include the recordings on our Let's Talk electronic newsletter. So I
Okay.
can't tell, Suzanne, can you advance the slide, or is it not advancing for you? There it goes. So going back to when we were talking about the commercials and we were talking about our different initiatives, how do we measure our outcomes and see if we're making an impact? This is embedded in all of our advocacy and empowerment goals. We try to monitor the outcomes for success to see those areas where we did really well, but also to look at areas where we need to make improvements or changes. And we do this by looking at data we collect from our websites, our email, our social media accounts, and then calls made to access. This happens on a monthly basis. Additionally, usually right after an event, we'll talk about how many people attended this year, how many people attended last year, and we use this data to guide our future decisions about changes that need to be made or things that need to be kept the same, because we never want to have an event just for event's sake. We want everything we do to have a purpose and an outcome attached to it, so that we can evaluate if we are meeting our goal to reach people and to engage them in the community and in our network. So next slide. I know there is more data on the written report that I submitted. I just wanted to touch base on a few highlights from that report. We do use Constant Contact now to deliver our email messages. So we monitor how many emails we send out. We call them campaigns, but how many email messages were sent out each month. We select based on our listserv. Not all emails go to everyone. So we may have a target audience. So in October, we sent about 8,000 emails, November 11, December 4. So our total for the quarter was 24,000. The industry opening rate is about 17%. Email is a primary way of communication now. So not everybody opens every email they receive. Our opening average is really good. It tells us then that the information that we are sending is important to people and it's what they want to be receiving. So included in here would be flyers, press releases, training materials, and then of course provider bulletins. Another way we track our outcomes is through newspaper articles. So this indicates how many articles appeared in local newspapers during the first quarter. There were about 40. One way of measuring metrics in the public relations industry is if you send a press release out and it's picked up in the newspaper, traditionally what will happen is you measure the column inches of that space and then you compare it with the advertising rates of that particular publication. So if an article was 5 columns by 6 inches, so 30 column inches, and they charged $100 per column inch. You multiply that, and that gives you the monetary number you would have spent to purchase that space. So for the first quarter, ours was 94,000. So next slide. This just highlights newsletters. We do try to have a multiple approach to reaching people. Not everybody has email, not everybody has a computer, so we look at all different ways and resources to communicate with people. Our Let's Talk is an electronic newsletter, so we again can monitor how many people received the newsletter. This is for stakeholders primarily, and then how many people opened it. Stepping Stones is mailed directly to individuals we served. So the first quarter of this year, the newsletter was sent to 15,000 people. The information in Stepping Stones is specifically geared toward those topics that are important to the people we serve, and it also includes stories written by people who are receiving services. In regard to our YouTube, we keep track of how many people are actually subscribing to our channel. Most of our videos are connected in some way or another to our website, so you can access them without actually going to our channel. And then we identified what were the top videos viewed during the quarter and for each month. So the COVID vaccination conversation we had in December had 171 views. And keeping in mind that people will view the videos in groups too. So we know in specialized residential settings, again, in our clubhouses, people sit together to watch these videos. And then we monitor, I think the ultimate goal for us is to say, are people visiting our website? Are people calling our access line? So if you look at November, we had 15,000 visits to our website. November was a particularly active month for us because we did have some grant money. We had a commercial that was on Comcast. We had some advertising billboards running specific to veterans. We had some information that was being aired specific to COVID. We had a direct mailing, which went to about 8,000 homes in Oakland County. And then if you look at all of those efforts, and then we usually will see the outcomes in the following month. So in December, almost 30,000 people went to our website to view information. Most of the time that information, people are looking for information either on the access, on our service information, and we do get a lot of people who visit our recipient rights page as well. So everything we do in a month, when we look at the following month, we tie that back into, was there an increased call or increase in calls to access? Were there increased visits to our website? Did we have new people join our social media sites as well? Was there anything specific that seemed to pique people's interest? And then we try to implement those things that we think contributed to those successes and to our upcoming marketing plans. And I think that's all I have. So, any questions from anyone?
That was a lot. Thank you. I see Judy's hand is up.
Hi, Judy.
Thank you. I just was wondering, in terms of the website, do you have somebody visit that pretty routinely to make sure that all the clicks work and that all the information is easily available? Do we do a maintenance
We
kind
do
of?
we do a maintenance because websites are very sensitive. Links can work one day and not work the next. We do have a number of people too that if a link goes out and it's important, people usually will call us pretty quickly, but we monitor and watch the website. I will share that there is a group of people. Dana had wanted us to do a redesign. And we're due for one. You should redesign your website about every 2 to 3 years to make sure it's relevant. So there is an RFP out to identify a new web design. One thing she also asked us to do, which I think is really going to be beneficial, is to put together a content expert committee for the website. So they will be, each individual will be assigned a certain section of the website as part of their responsibility to review, to make sure the information is accurate, to make sure the links are working, and then that team and group will meet together quarterly to talk about what they've identified. And then as part of that new website design, we did include somebody who has services, and we do have those conversations with the people we serve. We ask them to visit the website, let us know what's working, what's not. Somebody made a recommendation to have a person served page, so we added that. So that page is for individuals who have been receiving services for a while and they don't really need to go through Access, so they don't really need to go through service information. So there are a lot of different efforts that to go into place to make sure, because to your point, links break and we want to try and get them fixed as quickly as possible.
Okay, just what I wanted to know. Thank you.
You're welcome.
Melkaya?
Can you hear me?
I can hear you, Melkaya. Hello.
Hi, Christine. I was just wondering how you determine what information stays on the website. I was looking for past editions of our annual plan and work plan, and I was surprised to see that there weren't any older plans on the website. So that's just one example. How do we determine what we keep and what we don't keep on the website in terms of information for the public?
I thought we decided, I'll have to double check, but I thought we had made the decision to keep 2 years worth of plans up on the website. Because websites are meant to be quick references, sometimes it's better not to keep too much past information on there. So some of those are just best practices, looking at things that are recommended, like through Public Relations Society of America or different articles that we read. So our conversation, I think, when we talked about it before in terms of design, was that we would keep 2 years worth of plans on the website, because the strategic plan stays up for 3 years. So that that documentation is there in some capacity as long as the strategic plan is on the website.
But do we have, I didn't notice anywhere on there where it would tell somebody if it's specific information that you're looking for, how you would go about accessing that, or who you would ask to get that, like an annual plan?
Yeah, on our news event page, on our actual news landing page, there is a paragraph that says if you have any questions, you can email me. But I could modify that to say if you're looking for specific information, to please contact me.
That might be helpful, because I was looking for plans and I couldn't find them.
Yeah, no, I could do that. So we keep 2 years of plans because the 3-year strategic plan is on there. And we do have something that says you can email me, but if it needs to be more specific, that's an easy fix.
Okay, thank you, dear.
Mhm. Any other questions?
I am not seeing anything, Christine. I just wanted to check. I saw like the chat thing go on, but I don't see anything in the chat. Okay.
It looks
So
like there's a hand up, but I don't know if it's new or old. Oh, it went down. Nope, it's back. Let's see whose it is.
it's done. It's down.
Okay.
Um, okay, well, thank you so very much. That was great information and great work that you guys do to get all this information out.
Thanks, Sarah.
Yep, and we've got a chat that just from Mike Daly that people can contact customer service or, with the contact information as well. So thank you for that. All right, so we will hand it over to Stephanie for the quarterly clinical team update.
Hello, everyone. So I'm Stephanie Wilson. I'm the Director of Clinical Practice here at OCHN. So thank you for having me this evening. Tonight, I'm going to provide a quarterly update from the clinical team on some of the initiatives we're working on. So to give an overview before we get started of the department, what we work on the clinical practice team is ensuring the use of evidence-based and best practices within our network, working towards having person and family-centered planning for all individuals within our network, as well as the utilization management and review of all services. So within the clinical practice team sits the utilization management and review team. There are 17 staff members that are members of that team. And then there's also the clinical and integrated healthcare team. And there's 16 staff members that sit on that team. So some of the initiatives and responsibilities under the clinical practice team's umbrella include integrated healthcare and how that's working within our network, clinical review of supports and services provided to individuals, audit reporting within our network, and then utilization management and review. So for this Q1 update, I'm going to be touching on 3 different initiatives and providing an update for where things are at for Q1 so far for this fiscal year. Those initiatives include behavioral health homes, integrated healthcare, and suicide prevention efforts. So I am going to get started with behavioral health homes, or you'll often hear us reference this as BHH. So the health and wellness goal within the annual plan links back to behavioral health homes. And so within our clinical practice team, our goal is working towards the implementation of the behavioral health homes within our provider network and also with our community partners. So we are working towards that throughout this fiscal year. The what and the why of our work towards this goal really covers the expansion of care coordination efforts. This expansion is able to include more individuals across Oakland County, and I'll talk a little bit more about how we're able to provide that expansion when I talk about when someone is able to be eligible for this service. Keeping in mind a behavioral health home program is a service and it's not an actual physical home. So that's a good point of clarification I just want to make as well. So how we're working towards doing this is we are working on our partnerships with our provider network and community partners, and through those partnerships being able to enhance care coordination efforts. Now, care coordination efforts aren't something new to our network. These are often already in place with our provider network and with community partners as well. But through the behavioral health home program, we're able to help enhance some of those services. Some of those areas that are worked on and focused on in that care coordination enhancement include looking at the total overall health for that individual, as well as transitional care throughout their services and person and family support, including providing resources, education, and information to individuals. So a behavioral health care program can be offered to an individual who is eligible for BHH. These individuals, the eligibility is different than what it would look like to be eligible for, let's say, specialty mental health care services through OCHN, through our provider network. So to be eligible for behavioral health homes, someone needs to have Medicaid as their primary insurance. that is current, and they also need to meet one of 9 eligible diagnoses that is dictated through the behavioral health homes. So some of these diagnoses include, anxiety or depression. So thinking about individuals who have Medicaid within Oakland County and who have one of those 9 qualifying diagnoses, that's a much broader ability for us to be able to provide that care coordination as far as eligibility goes related to those who are eligible for, let's say, the specialty mental health care. So that's where we're really able to have that expansion, because someone could be qualify for behavioral health homes that wouldn't necessarily qualify for OCHN's specialty mental health care programs. And it increases our capacity to be able to provide that care coordination within Oakland County and making that more accessible for individuals within the county to be able to access that level of care coordination and care. So I do have on the right-hand side, and sorry if that is pretty tiny, but for Q1, some BHH enrollments, and we have by provider. So this is for Q1 data, the providers that are currently enrolling, how many they've enrolled. That darker purple color means pending review, and so what that means is they've submitted the request for enrollment, and our behavioral health home coordinator, Emily Patterson, reviews all of that information. So there may just be some paperwork pieces that are getting worked out until those are approved. So we can see there we do have the providers that are enrolling currently. That will be growing. I know we've had an additional provider just today, I know, that started enrolling individuals for behavioral health homes, so that is exciting. I also included in the completion status the number of enrollees we had as of 1/26. I did check our behavioral health homes dashboard that we have, and right now, as of today, there are 232 enrollees. So the good news is that number is constantly growing. Day to day, we're getting new enrollees, and so this is going to be an ongoing goal that we're working on throughout this fiscal year, with the desired outcome of expanding our reach and providing care coordination services throughout Oakland County. The next slide, Suzanne. So for the budget and funding information, OCHN receives funding from the state of Michigan, and this includes state and federal Medicaid dollars that are supporting the behavioral health home program. And this was included in our budgeting for FY21. So any questions related to behavioral health homes before I move on?
I'm not seeing any hands up, so I think we can.
All right.
I'm sorry, Sarah.
Oh.
I couldn't get my hand up quick enough. I guess I'm just a little would like a little bit of clarification as to what exact services are being provided to the participants of the behavior home benefit.
Yeah, that's a great question. So a lot of the services are going to sound familiar to what was being provided for individuals. And so it's not a new concept of the care coordination piece, but I think thinking about how it's captured under behavioral health is how we're able to enhance some of those. So thinking about traditionally how case managers and supports coordinators are usually often providing a lot of that care coordination, right? Coordinating with a primary care or coordination with specialty doctors or different things, whether it be transportation related to getting some of those pieces to appointments and that sort of thing. Through the behavioral health home, the ability to enhance that is when we're capturing like behavioral health home encounters that are submitted on a monthly basis. You could count an encounter, let's say that supports or the behavioral health home manager, overseer for that individual, which could be a case manager, supports coordinator, is doing some outreach to a specialty healthcare provider, for example. And so they're making some phone calls, they're corresponding, via letters or different things like that. Those things which traditionally wouldn't be coded under like a case management or supports coordination code could be counted as a behavioral health home encounter. So it's really opening the ability to some of those things that were already taking place, be able to have those providers be able to count that as an encounter through a behavioral health home and be able to have the opportunity to provide enhancement in those areas because they can receive an encounter and some reimbursement for those services that previously with supports coordination or case management, maybe they weren't able to.
So they're providing care coordination, but our agencies providing the behavioral health services too, like therapy or psychiatry or those kind of things. I guess that's what's confusing to me.
Yeah, so you know, as I mentioned, the eligibility can be broad for behavioral health homes. So we really have started with targeting individuals who were receiving services, and that's why you see those enrollments within our provider network, targeting individuals who were open to services, right? So they were open with services, maybe targeted case management, whatever service they may be aligned with, and then they can also receive behavioral health homes. So it's not impacting, you know, they're still able to receive the full a variety of services that they would be receiving through what other programming they were receiving. This is an enhancement to that.
Okay, so we're not providing anything in addition to other than case coordination.
The care coordination is the main piece, and there is some information I can get to where it really spells out very specifically in the behavioral health home handbook, you know, what they consider as care coordination pieces, and so those are the specific pieces for the behavioral health home component.
Okay, so I guess the other question I have is there were a lot of people that used to receive services with us before that didn't meet criteria for severe mental health services. Would they be able to come in under the behavioral health home benefit or no?
So the behavioral health home program doesn't necessarily, it qualifies someone for that program. It doesn't qualify someone to return to specialty or qualify, I should say, for specialty mental health care. So that's where our community partnerships are going to come into play. And so we're working with like Honor Community Health currently on getting up and going. So they may have individuals, right, that are receiving services through Honor Community Health, but may not qualify necessarily for specialty mental health. And so they could still receive that behavioral health home component through their services through Honor, but it wouldn't necessarily allow them to be open back through specialty mental health care services, if that makes sense, because the eligibility criteria is different for the program.
Right.
Yep.
But they do get some sort of behavioral health service through
There,
this.
there is a component, yeah, of coordination and care coordination through that.
Okay, care coordination, but through Honor, would they be reserving like psychiatric or medication? That's the part I'm trying to understand.
Yep, they could receive either of those through Honor. Yep. It would, you know,
Okay,
depending on that individual's need, but they could access
right.
that. Yep,
Okay, thank you.
absolutely. Hmm. Any other questions on behavioral health homes? All right, so I will move into integrated healthcare as the next initiative that I wanted to cover this evening. So there are a couple of different annual plan goals that tie into integrated healthcare efforts, including technology and innovation and health and wellness. So under integrated healthcare, we're looking at having the ongoing implementation of the complex case management program, continued care coordination with our provider network, with Honor Community Health, and with the Medicaid health plans in Oakland County, and then the use of the HEDIS measures as we're looking at those to identify different trends, individuals with higher levels of risk, those sorts of areas, and how we're impacting that. So the what and the why of the integrated health, we're really looking at having those nurse case managers be able to assist individuals who may be identified through like I said, the HEDIS measures, through care coordination efforts as high risk, having physical and behavioral health conditions. And so being able to work with those individuals to help improve those outcomes related to their integrated care as a whole. So one of the ways that we're looking at doing that is by review of HEDIS measures. So one HEDIS measure specifically that we're focusing on this year is HEDIS measure 304, which is diabetes screenings and related to the completion of having that screening. We have a goal of 80% currently. And so see over on the side there, I do have some metrics just to report on from this fiscal year. I will say that we do have a 2-month data lag with our population health management tool. So I wasn't able to pull for the full quarter. I could pull some numbers for October and November. But when I come back to report next time, I'll be able to report out on the full quarter and where we landed with our numbers. For October for FY21, we were at 77%, and for November, we were at 74%. I will say too, there is some fluctuation there, and that is to be expected between those numbers, some slight fluctuation, because it's going to vary depending on month to month. We have individuals who are opening and coming into service, as well as the number of individuals who are discharging. So while they should remain close, there will be some variance there. When we ended last fiscal year in FY20, we were at a 70% completion. So I think this is a positive trend. We're trending in the right direction and seeing some increase in October and November. And like I said, it'll be good to take a look at those numbers for Q1, but it looks like we are making some headway to that goal of 80%. Another piece of the how is that the nurse case managers are coordinating with the 8 Medicaid health plans in Oakland County to provide those care coordination pieces along with the OCHN provider network. So individuals identified through care coordination, and we do utilize the Care Connect 360 tool, which gives information such as admissions, discharges, and transfers from emergency departments and inpatient psychiatric and physical health care stays. So utilizing that information in our coordination with those providers and health plans as well. And then through our complex case management program. So when this is accessed, it can be if an individual is accepted or identified for complex case management or care coordination, using the HEDIS measures and CC 360 to identify some of those higher risk areas. And then looking for our overall impact or outcome related to integrated healthcare is really to work towards improving the person's served overall health and improve that person's experience of service by taking an integrated approach and really focusing on the whole person. So throughout the year, we do some follow-up surveys related to the person's experience with service. And so as we have some of that information, I would be happy to share that as well. This is a goal that is going to be in progress through the year, and we'll continue these efforts throughout the year and provide updates as they come. So for budget and funding.
I'm sorry, before you go on,
Sure.
Could you break down the acronym for HEDIS measure so that the newer people know what that means, please?
Yes. Let me just make sure I'm saying it correctly here while it's health effectiveness data and information set. So those are reports that we're able, yeah, no problem, thank you. That's data that we're able to receive through our population health management tool to be able to access that data to see for individuals served.
And you got the acronym correct.
Thanks. I think you can go to the next slide, Suzanne, please. So the budget and funding information, there's a combination of Medicaid administrative and grant funding that is utilized for integrated healthcare efforts, and that this is included in the budget for FY21. So questions related to the integrated healthcare efforts.
I don't see any, but I say that and then sometimes I miss it. But not, yep,
Oh, I
Dr.
think I,
Haas.
Yeah, so hello, my question is about the HEDIS measures. How many indicators are, how many possible indicators are there for the people that we serve? And out of those, how many are we looking at? I mean, I noticed that it's only mentions diabetes.
So yes, that's a good question. I included that one. That's one of the ones that we're really focusing on as far as our nurse case managers and doing outreach and working towards that goal of 80%. There are, I believe it is 9 other measures specifically that we are looking at. There's a number of different measures. And so trying to find that balance of focusing on an amount that we feel like we can create some change with. Some of the measures have to do with adherence to like antidepressants within the first 6 months of treatment, and then looking at subsequent months are some of the measures. Also, number of psychotropic medications prescribed and looking at the youth population as well. So I believe there are 9 total, and I can certainly get all of them for you, but they look at a variety of different areas. So the diabetes is just one that we look at.
Yeah, I think that that is something that will need a little more time to look at. So at some point, if a presentation could be made under any other agenda or something, that would be helpful, because the psychotropics and the couple of others that you mentioned are quite important measures, and we should have at least some understanding of what they are and how they impact our citizens.
Yeah, absolutely. And we could definitely spend, a decent amount of time talking about some of those measures. So I appreciate that feedback.
Thank you.
Mhm. Any other questions? All right, so I will move on to the final initiative. The suicide prevention efforts is the last area I want to discuss this evening. So this is related to our services and supports goal in the annual plan, working towards continued suicide prevention efforts across our OCHN network. So the what and the why, we want to continue the zero suicide practices that we put into place several years ago and continue to make sure we are adhering to those and following that. So really with the overall goal to improve supports provided to persons served at risk of suicide. So how we're working towards that, some of the things happening for this fiscal year is we have added for FY21 that all OCHN staff are now required to take a suicide prevention training. So this is new to this year. In previous years, clinical staff had a certain amount of suicide prevention training hours that they needed to complete. And so this is the first year that all staff will be required training, and really hoping to promote an increased awareness across our organization. We're also continuing the implementation of the clinical pathway to suicide care. So this clinical pathway was introduced last fiscal year, and I do have over to the side here for fiscal year 20, there were 311 enrollees on the clinical pathway, which was great. We were excited because it was the first year and we were able to really identify some individuals who were at risk of suicide and place them on this clinical pathway. For fiscal year 21, for quarter 1 so far, we've had 102 enrollments on the clinical pathway. And so we're excited about that, because what that's telling us is that if the numbers keep trending this way for this year, we're seeing an increase of individuals who are identified at risk of suicide within our network. It shows that there's an increased awareness and understanding among our providers on how to utilize that and how to identify individuals who are in need of that care. So it looks like if the numbers continue, that we will have an increase in those enrolled on the pathway, which is good that we're identifying individuals for that care. We also have ongoing internal zero suicide work group. So this work group is within OCHN and reviews our protocols, practices, policies related to making sure that we're keeping in mind all of those zero suicide practices and that it's informing all parts of the work that we do. And then for this fiscal year, something that started in Q1 is that we started an external zero suicide work group. So this includes OCHN along with all of our providers in our network were invited to participate. And the first work group took place in Q1, where we're talking about that zero suicide practice across our entire network and how that is being implemented among our provider organizations, talking about things like the clinical pathway to suicide care, getting feedback, and providing updates as needed to those areas. So that's an exciting new addition to this fiscal year as well. So these meetings, many of them occur on a quarterly basis. I think the new external work group is occurring every other month right now. And so during these, there's ongoing review of practices, updating information as needed, getting input and feedback, and then talking about how we're really able to work on implementing those strategies in all of our day-to-day work across our network. So really the overall impact and outcome that we're looking at through these efforts are that people served are receiving the highest quality support, that we're increasing awareness among our provider network, and also increasing skill development for the clinicians who are practicing, and then in turn hoping that we are seeing a safer, suicide safer community as a result of increasing that awareness and skill development. So this is also ongoing and in progress. We'll be working on these efforts throughout fiscal year 21 as well. Next slide, please. So the funding source for the suicide prevention efforts is administrative, and this was included in the FY21 budget. So any questions related to the suicide prevention efforts?
Melkaya?
Thank you, Sarah. One question I have, I really appreciate the detail, the level of detail and attention that's being given to zero suicide. But in light of the pandemic and the increase of suicides that we've had over this past year, has there been any effort to re-examine the model to see if it's still relevant in based on what's been happening over the past year?
Yeah, I think that's a great question. So I was actually just talking with one of our clinical analysts who leads a lot of our suicide prevention efforts, and this came up in the external zero suicide work group that happened. During the pandemic and how things are looking, I think the zero suicide model is applicable. We just might need to look at, how we're implementing things across our network and if there are things we can do to adjust or tweak it. But I think that's a good point, and I think it's something that came up in that group. So there's going to be continued work around that to look at how we need to adjust and change with the change in climate right now.
Thank you.
Mm-hmm. Other questions?
I'm not seeing any, Stephanie. Thank you so very much for all this information. It's a lot of great work that you're doing and your team is doing, and we appreciate it. So
thank you.
Yeah. So we will move on to the RRAC recommendation with Vicki.
Good evening, and thanks for the opportunity to present the recommendation by the Recipient Rights Advisory Committee. They did meet on January 7th, and we do have a member who is concluding her first three-year term, and that is Elizabeth Janovitz. So the RAC committee did discuss, and Elizabeth did say she wanted to be reappointed for a second term. The committee did discuss her attendance and her participation in that group, and they unanimously recommend that she be appointed to a second term. The board had appointed her to her first term in February 2018. So this is an item that will need to be approved at the upcoming board meeting. Any questions?
Jonathan?
Thank you. Vicki, so this would be the reappointment of Liz, which is great because she was really active on, on the RRAC. How many additional slots are there still open on RRAC?
Sure. Currently, there is one community member at large position, And then there's just an overall general position that's open. And then we do have another member who will be terming out in April. So then there'll be another vacancy.
So basically 3 between now and then.
Correct.
Okay. And if people are interested in participating, they can certainly reach out to you or your staff to get an application.
That is correct.
Okay. Of course, I'm doing that to plug it in case someone's watching tonight.
Thank you.
Welcome.
Any other questions or comments?
I am not seeing any, so we will, address that at the board then for a vote next week. I think it is. My dates are getting our next board meeting. All right, thank you, Vicki. So we will go ahead and move on to other business with an Open Meetings Act update with Kalana.
Hello. So I wanted to just touch base on the Open Meetings Act. I know this was discussed at the previous board meeting in January. However, I'm not sure if there were any questions. At a high level, as you may all be aware, based on the memo that has been circulating, the OMA was amended recently to allow for remote meetings to be held for any reason through March 30th of 2021. After that time, meetings may continue to be held remotely for very limited reasons, one being military duty, another a medical condition, or the a declaration of a state of emergency. At this time, we are continuing to meet remotely through the March date. However, after that time, if any meetings occur remotely, the persons attending remotely must announce that they will be participating remotely and specify that their county, city, township, village, and state where they are physically located. At this time, we do not have that practice, but from my understanding, there is a desire to start announcing the city and state where each person is at the outset of the meeting for the board members. And if so, no other additional information will need to be given at that time. After that time, of course, we will work. Our OCHN is working on a transition plan to begin or reinstitute meetings in person should it be considered safe to do so for not only the board members, employees, as well as members of the public. At this time, are there any questions regarding the requirements and the recommendation?
Kalana, it's Sarah. Is there, I know in the past there wasn't really a definition, but for folks that have a medical condition, is that just up to that person do they have to share that information, or is there parameters around the medical condition?
The statute just says a medical condition. So it does not go into detail as to what the requirement of the medical condition is, but assuming it would be something that would prevent you from participating in the meeting in person.
Okay, and then I presume if things move forward, and starting in April, if we were to need to be in person for meetings, unless something changes between now and then, there'll be a plan that folks are working out to ensure the physical distancing and all of that. I mean, there's probably going to be caps on how many people can be in the room and everything. So there's a team that will be working on that.
Absolutely. So that is currently in process right now. The administration team is actually putting together a plan to ensure the health and safety of each member should we resume in-person meetings. And I'm sure that once that's fully completed and we have I think a clear understanding of where we are and where we're headed in the upcoming months, that will be shared with the board as well.
Okay, thank you. And I see Judy had her hand up.
Yes, thank you. I was just wondering, in the past, we've had some updates regarding open meetings, and there was discussion regarding appointed and elected boards. Is that clear to us now? And also, what would the trickle down be, say, for instance, for the Citizens Advisory Committee and the Recipient Rights Advisory Committee in terms of open meetings?
So I'm sorry, I don't understand the first part of your question. You said there was.
Okay, so we're an appointed board. We're not an elected board.
Correct.
And so we had feedback from our lobbyists indicating that the discussion had centered around if there's any distinction between the two, being an elected or an appointed board. And my question would then be, is there a trickle down in any way for the meetings of the Recipient Rights Advisory Committee or the Citizens Advisory Committee? In terms of being under the Open Meetings Act.
So they are subject to the Open Meetings Act anytime there is a committee of under governmental authority, because this is a public organization. The Open Meetings Act would apply, and given that decisions or policy decisions are being made, then the Open Meetings Act would apply to that particular meeting.
Okay, so does that, I can see where that applies to us, certainly the board, but I just was curious about the committees that are like a subset, like the Rights Advisory Committee and the Citizens Advisory Committee. Are they governed by all of the same legalities?
So generally, committees are not necessarily a part of that unless there's a quorum of the public body. However, practice has always been to have those meetings held in open under the OMA, or held in compliance with the OMA.
Okay, so what I'm hearing is from community people I know that there is concern about not our board, but the committees. There's concern about attending in person. Is there anything that we can provide in terms of guidelines for, like I said, the Citizens Advisory Committee or the Rights Advisory Committee?
In terms of hosting their meetings, you mean?
In terms of, do they have to be present rather than participate remotely? I mean, there's transportational issues, a whole lot of things that are, kind of challenging for people who might rely on other people to get them to meetings, things like that. It gets a little bit complicated sometimes, and there's concern. That's all. I'm just wondering if there's any clarification or something we can offer to people.
So I can't speak to what the committees intend to do in terms of hosting their meetings. My assumption would be that given that COVID isn't going away and it still presents a health and safety concern to everyone, that the meetings will continue to be hosted remotely so that people can participate remotely, should that continue, for those to also limit people coming into the building once we do open. However, I can certainly look into that and get back to you on that note.
Well, I think that I would appreciate that very much, but I think maybe that's a discussion to have at those two committees too, to find out what people's questions and worries might be, more so than for our board, because I think we know what our guidelines are.
Sure.
Thanks.
And just one follow-up from me, Sarah. So when folks are planning on the return, I guess just trying to figure out, and I'm sure it's on everyone's mind, but what's going to happen if we do hit capacity in the room? So will then folks, is there a clause or something for attending remotely, or those people that do want to attend, but we have too many? Because thinking of that room, I don't know, I can't think of what the room capacity is, but there could be an issue with, how many people are in that room and how we would address that.
Certainly. So I know this has come up in the past and we've discussed having an overflow area. However, I still think, given the concerns with health and safety, transportation, overflow, having those meetings still being recorded and hosted in this format will be beneficial so that we are not impeding access to the members of the public. The last thing we want, because you still run into the issue, the entire purpose of the OMA is to have an open meeting so that people or members of the public have access to information and the decisions that public officials are making on behalf, with public dollars, right? I think that hosting the meetings in this electronic format, even if we do resume in-person meetings, will be beneficial, like I said, to not only employees, board members, and members of the public for health and safety reasons. It also continues to allow for that access to that information if there is an overflow matter, because the one thing we don't want to do is turn people away. So I think that continuing to host it in this, or making it available in this format would be to the benefit of the organization to prevent any of those claims as well.
Okay, thank you.
Sure.
And the way things change, it might be different next week, right?
You never
We're
know.
closer to end of March, I guess, but
Yeah.
all right. Any other questions for Kalana? All right, well, thank you so much. We appreciate your time and expertise. So this brings us to our final opportunity for public comment. Do we have any additional public comment?
We do not have any additional public comment this evening, Sarah.
All right, thank you, Christine. So we will move on to board member comments. Sheila, if you could go through the roll, please.
Sure. Ms. Summers?
Thank you, Sheila. Just thanks to everyone who worked so hard to put this meeting together and everyone who participated. I always learn. I appreciated knowing more about our outreach, using media in the community for people who are looking for information or need to be reminded of information. And I wish you all continued good health and please stay safe. Thanks.
Ms. Newman?
I just want to thank the staff again for another good meeting, good information, and I really appreciate the efforts that are being made to chart new waters in terms of getting the word out about what we do. I know it's going to be very beneficial, so I really want to give kudos to Dana and to Christine for moving in this direction. Thank you so much for that. Have a good day, everyone.
Dr. Taub?
Two things. One, thank you everybody for the presentations. And I'd like to thank Anya especially because the financial reports, the way you're giving them, I can even understand them, where if you were throwing the spreadsheets out, I wouldn't. So keep that up. I appreciate it. And secondly, dropping back to a motion that's going to come before us at the board meeting next Tuesday on channel 4 and 7, the budget approval. I don't see any reason that's not going to pass, but I don't think motions like that should be stuck in the middle of a consent agenda or a budget. You know, it's above $100,000. It should be a standalone vote. And then you won't have somebody 8 months later saying, when did we vote on that? And then somebody else saying, well, that was in the budget or that was in a consent agenda on a certain date. It's being brought before the board. It should be a motion. Any discussion that there is, an approval or not. And a consent agenda is like the minutes of the previous meetings and stuff that you can bunch all together and approve all at once because there's not going to be any discussion unless there's a change in the minutes. So I would suggest that we just put that in the regular agenda. Or I'll bring it. If not, I'll just when this consent agenda comes up for approval, I'll just ask to have it moved to the regular agenda then. And everybody stay safe. I'm getting my second shot next Monday. So whatever the legislature decides on whether we can keep meeting remotely, which they probably will, because the immunization program, people can't get the shots because of scarcity. So I don't think we'll have enough people immunized to have in-person meetings. That's all I have.
Ms. Root?
No comment tonight. Thank you.
Dr. Hahn? Mr. Furman? Oh, Dr. Hans, are you still here? I think she logged off. Mr. Furman?
Yes, I really want to again thank the staff responsible for putting the presentation together. Specifically, I really enjoy the kind of snapshots on the quarterly elements associated with each division of OCHN that presented tonight. So it really gives us kind of a at the minute update with what we're doing as an agency, and I really find that beneficial. So thanks so much, and everyone be safe.
Mr. Torres? Mr. Torres, if you're on, I don't know if your mic is on.
He had to sign off early, Sheila.
Oh, okay. Mr. Lindemere?
Hi, just wanted to thank Sarah for leading the meeting today. I was concerned about my ability to participate in the meeting, so I really appreciate the fact that she was able to step up and help out. So thank you.
Miss Namie Dyer?
Yes, I just wanted to say thank you to all the presentations. I really enjoy hearing and learning more about all of the different advocacy efforts. It's just really awesome to see everything that's been going on with all of the efforts that OCHN makes. So I always really appreciate that. And I just wanted to say, everybody, please stay safe. I may not be here for the next few meetings because I'm actually expecting my second child in the next couple weeks. So if I don't talk to a lot of you, I hope everybody does stay safe. And as Dr. Taub was talking about, hopefully more people will be able to get vaccinated in the coming weeks. I'm certainly hoping that I'll be able to get mine soon too, but stay safe, everyone, and hopefully I will talk to you soon.
Mr. Landsman?
First of all, I have a few things. First of all, I want people to go out to Oakland County and register for the vaccine. Do it once, do it twice, do it 3 times, whatever it takes. I did recently get an email from them to say that they're ready to schedule me for one, but I've already started into that process through Beaumont. But also reach out if you have a Beaumont doctor and see if you can't get a register through them, register through the county, register through McLaren, and that will give you 3 different areas possibly that get you a shot sooner or the series sooner. So please think about that. I can tell you from where I'm at Blue Cross, while we were going to go back into our offices mid-June, it's now looking like it will be somewhere in the fall, only because we don't think that the vaccine will have hit herd immunity, so to speak, from a distribution and administrative perspective. So again, get your shots. Second, I want to thank all the folks that put together the presentations and the insights today, more information about our financials, what those numbers do mean in the dashboards, and how those numbers grow and the people we serve. And thinking about the people we serve, Christine, I'm glad to see that we are doing a lot more active outreach to hit the, if you will, the 4 corners of the county, to provide more services to more people that either may be hesitant or not aware that we are here to exist to serve them. So I think that's good, as well as the 4 corners of the demographics, because when I look at our numbers, I don't always get the sense that we are providing the services across the demographics, so across the races, across the religions. So I'm glad that we're reaching out and that we are trying to become more engaged, across the various communities of Oakland County, even when it's difficult to do that because we're all locked down. So thank you all. And then the last item, it's been brought up a couple of times about the consent agenda. So I just want to say, yes, if there is a board member that has some heartburn over that, yes, please recommend that we pull it out, and we will do that at the board meeting and vote on it separately. Okay, that's it. Thank you.
Miss Bernard is not here. So Dr. Guadalupe?
I would just like to thank everyone for the presentations. I'm excited to hear about getting our name out in the community a little bit more and with that marketing. So I think that'll be great. Great to be out there and have people see the wonderful services that we provide. And that is it. Thank you. So at this time, the meeting is adjourned. Thank you, everyone. Have a good week.
Be well, everyone.
Have a good night, everyone.
Thank you. Good night.